Today, we'll be covering the nutritional aspects of pregnancy and breastfeeding. Pregnancy is a very special time. Most parents-to-be want to do everything possible to maximize their chances of having a robust, lively newborn. Most women begin improving their health and nutrient intake, especially folic acid, as well as eliminating potentially harmful habits long before becoming pregnant. Despite these intentions, the number of infants who die in America is much higher than any other industrialized country. Pregnancy or gestation may be the most sensitive stage of the life cycle. Nutrient and calorie supplies at this time impact the final outcome. An infant's chances of survival depend greatly on both gestation length and birth weight. The closer the gestation period comes to full term, the greater the physical maturation and birth weight. Full-term gestation period is 39 or 40 weeks. Preterm is when they're born before 37 weeks. They may have medical problems and low birth weight when they are preterm, which is weighing less than 5.5 pounds. And this is usually linked to suboptimal maternal nutrient and calorie intake. The term small for gestational age is infants that weigh less than expected for their gestational age. To put this in perspective, this would be a full-term gestational period of 39 or 40 weeks, and the baby is weighing 5.5 pounds. Gestation begins at conception when a sperm unites with an egg. About 30 hours after conception, the zygote, as the fertilized egg is called, begins the lifelong process of cell division. The next stage begins 2 weeks after conception. The zygote is now called an embryo. When the embryonic stage begins, the cells have already separated into a stack of 3 thin layers. One layer of cells, called the endosperm, will develop into the digestive system, liver, and pancreas. Another layer, the mesoderm, provides the cells that will become the skeleton, muscles, heart, and blood vessels. From the last cell layer, the ectoderm, will be the skin, nervous system, and sensory organs. When this stage ends after week 8, the embryo is quite complex, yet it is no larger than a pea. The major organs are in place, and some, such as the heart and liver, have begun to function. From week 9 until birth, the developing offspring is known as a fetus. The fetal stage is when the most rapid growth occurs. About 90% of all fetal growth occurs in the last 20 weeks of gestation. During the fetal stage, length increases 20 times or more to an average of 20 to 22 inches. The weight is going to skyrocket to an average of 7 to 8 pounds, and body proportions change rapidly too. When this stage begins, the head and the body are nearly the same size. Between 21 and 30 weeks, body proportions shift to be similar to those of newborn infants, although the fetus is still quite slim and has loose, baggy skin. Body fat's rising from less than 1% at 20 weeks to 16% by 38 weeks. Premature infants also are at risk of nutrient deficiencies because nutrient stores do not accumulate until the last 4 to 6 weeks of gestation. By 38 to 40 weeks, a healthy fetus has built substantial nutrient stores and developed sufficiently to thrive outside the uterus. Pregnancy is divided into 3 periods called trimesters. There is a window of opportunity called a critical period for cells to develop into a particular tissue or organ. Most of the critical periods occur during the first trimester. For example, critical heart development occurs during the 3rd to 6th week. Critical tooth development happens during the 6th to 8th week of gestation. Nutrient deficiencies or excesses like certain pathogens, trauma, radiation, tobacco smoke, and toxins such as drug and alcohol during a critical period can interfere with normal development, causing effects such as physical or mental abnormalities to spontaneous abortion, which is a naturally occurring premature termination of a pregnancy prior to 20 weeks of gestation. Early spontaneous abortions are also called miscarriages, and they usually result from a genetic defect or a fatal error in fetal development. A zygote nourishes itself by absorbing secretions from glands in the uterus and digesting some of the uterine lining. As a zygote develops into an embryo at week 9, the placenta begins to form inside the mother's uterus, and the placenta delivers nourishment to the developing embryo and fetus. The umbilical cord is the connection from the placenta to the fetus, and the nutrients travel to developing organism from placenta, and the waste travels in the opposite direction. The placenta's size and ability to support fetal growth depends on the mother's nutritional status. Poorly nourished women have smaller placentas with fewer blood vessels and smaller cells. This may hinder optimal fetal growth and development. To meet a pregnant woman's calorie and nutrient needs, more nutrient-dense foods should be consumed. Sufficient quantities of calories and all nutrients are needed for a favorable pregnancy. A pregnant woman needs extra calories to support the growth of her own tissues as well as those of the fetus. Additional calories are also needed to fuel the extra metabolic workload pregnancy puts on a woman's heart, lungs, and other organs. Few, if any, of these extra calories are needed during the first trimester of pregnancy, when the developing offspring gains little weight. During the second trimester, a daily increase of about 350 calories is recommended, and in the third trimester, a daily increase of about 450 calories is recommended. Women who begin pregnancy overweight or obese should aim for a somewhat smaller increase in calories. Those who are in their teens, who are underweight or physically active, will need more calories. Underweight women who increase their energy intake are more likely to give birth to healthier babies and experience fewer infant deaths than those who do not increase energy intake. Women who are physically active during pregnancy may need to increase their intake by more than 350 to 450 calories because greater body weight requires more energy for activity. Infants born to women who consume too few calories are more likely to be born small, die soon after birth, develop a thrifty metabolism later in life, increasing the likelihood of developing type 2 diabetes and obesity, develop heart disease, high cholesterol, high blood pressure, and experience an impaired immune function. Cells grow and develop at a rapid rate during fetal life. Over the course of gestation, a single-cell zygote will divide millions of times, creating trillions of cells. Although every nutrient plays an important role in manufacturing these new cells, the roles of protein, essential fatty acids, zinc, folate, vitamin B12, and iron are especially noteworthy during pregnancy. Protein intake recommendations for pregnant women are more than 50% above those for non-pregnant women. Even with this substantial increase, insufficient intakes of protein are uncommon in the U.S. and Canada, because this nutrient is so plentiful that women, pregnant or not, consume amounts exceeding the RDA. Essential fatty acids are required for normal fetal growth and development, particularly for the brain and eyes. Sufficient intakes, especially of omega-3, may improve gestation duration and infant birth weight, length, and head circumference. Zinc intake by both pregnant and non-pregnant women often is less than the RDA. However, we typically do not see deficiencies. Severe zinc deficiency may cause birth defects, fetal growth retardation, premature birth, and spontaneous abortion. Folate and vitamin B12 are critical for the synthesis of DNA in fetal and maternal cells. For example, red blood cell formation, which requires folate, increases during pregnancy. When folate intake is insufficient, fewer red blood cells are synthesized, causing folate-related anemia. Insufficient folate intake may also cause premature birth, low birth weight, fetal growth retardation, spontaneous abortion, poor placenta development, and other pregnancy complications. Folate deficiencies in the very early stages of pregnancy also can cause neural tube defects. The neural tube is tissue that develops into the brain and spinal cord. It starts as a shallow groove running down the back of the embryo that at 28 days of gestation folds in on itself to create a tube. If it fails to close at the top, the brain does not fully develop and death occurs soon after birth. The spine is incompletely formed when the tube does not seal at the bottom, causing spina bifida. Depending on the severity of spina bifida, children may be paralyzed or have curvature of the spine, dislocated hips, or other physical handicaps. There is some evidence that poor folate status also may play a role in the development of heart defects, other birth defects, and autism. Iron needs rise significantly during pregnancy, mainly because of the increasing number of maternal red blood cells and accumulating fetal iron stores. The increased demand for iron puts many pregnant women at a greater risk of iron deficiency anemia than individuals in any other stage of life. Iron stored prior to pregnancy can supply some of the extra iron. However, most women enter pregnancy with poor iron stores. To help meet iron demands, the maternal iron absorption increases up to 3 times, and this mineral is conserved because menstruation stops during pregnancy. Even with these adaptations and a carefully planned diet, it is very difficult to meet the need for iron. Many experts recommend that pregnant women take a low-dose iron supplement of 30 milligrams a day. However, iron can interfere with zinc and copper absorption and utilization, so women taking iron supplements also may need a zinc and copper supplement. Iron supplements can decrease appetite and cause nausea and constipation. Taking them between meals or just before going to bed can minimize these problems. Iron deficiency anemia can cause low birth weight, premature birth, and infant death, and it may result in low iron stores in the infant. Pregnant women with this condition may experience preeclampsia, labor and delivery complications, and an increased risk of death. The fetus needs large quantities of vitamin D, calcium, phosphorus, magnesium, and fluoride for normal bone and tooth development. Of these, calcium and vitamin D need particular attention. The mother will absorb calcium more efficiently, and it can also pull calcium from the mother's bone if it's not in the diet. And a vitamin D deficiency can lead to osteomalacia in the mother and rickets in the developing fetus, and we covered both of these terms in the previous chapter. It is a common myth that women instinctively know what to eat during pregnancy, and that by responding to cravings, they get the nutrients they need. Many women report craving some foods or beverages during pregnancy. Cravings range from the unusual, such as clay and rubber bands, to the ordinary, like ice cream, pickles, and chocolate. In addition to cravings, many pregnant women experience aversions to certain odors and flavors, such as alcohol, eggs, coffee, fried foods, meat, and tomato sauce. The cause of cravings and aversions still to this day remains a mystery, but they may be related to hormonal changes in the mother or family traditions. Some women also practice pica, which is the eating of non-food substances, such as laundry starch, coal, clay, and tire inning tubes over a sustained period of time. Abnormal cravings for certain food items, such as baking soda and cornstarch, are also considered pica. Pica is not unique to any group. It is practiced by both sexes and many racial and ethnic groups. It is especially common among women who during childhood observed family members eating non-food items. It seems to be more frequently practiced during pregnancy than other times. The potential dangers posed by pica outweigh any perceived benefits. Some non-food substances, such as mothballs, toilet bowl freshener blocks, and chalk, may contain dangerously high levels of toxins such as lead. Clay can block the intestines and may contain parasites and pathogens that impair mineral absorption. Laundry starch is high in calories at 1,800 calories per pound, but lacks all other nutrients except carbohydrate and can lead to malnutrition and obesity. Pica can have consequences for the pregnant woman, such as malnutrition, anemia, and death, and her fetus, such as premature birth, low birth weight, poor nutrient stores, and death. A pregnant woman's nutrient needs increase dramatically, but her calorie needs increase only a small amount. Selecting low-fat foods help keep calories in line and can increase the nutrient density of the diet. The recommended daily increase of 350 to 450 calories doesn't sound like much, but the usefulness of this depends on how the woman decides to spend those calories. 2 soft drinks or chocolate candy bar supplies nearly the number of extra calories daily a woman needs in the last 2 trimesters and provides almost no nutrients. On the other hand, 2 glasses of skim milk, a small spinach salad, and a bowl of strawberries will also meet 2/3 of the calcium and vitamin A and 1/4 of the folate, and will exceed the vitamin C needs for 1 day, all for less than 350 calories. According to My Plate, they have a recommendation for the first trimester, which is 2,200 calories a day, 3 cups of calcium-rich, low-fat food, 6-ounce equivalents for protein, 3 cups of vegetables, with 1 cup being rich in vitamin C and 1 cup rich in folate, 2 cups of fruit, and then 7-ounce equivalents for grains. The My Plate diet plan recommendations for the second and third trimester are 2,600 calories a day, 3 cups of dairy, 6.5-ounce equivalents for protein, 3.5 cups for vegetables, 2 cups of fruit, and then 8-ounce equivalents for grains. They should also include 6 to 7 teaspoons of vegetable oils. There are special supplements formulated for pregnancy, which are prescribed routinely for pregnant women by most physicians. You can get some of these over the counter, and some of them are through prescription because of their high synthetic folic acid content, which could pose problems for others, such as older people. Prenatal supplements are also high in iron, but it's important not to exceed the recommended dose because of mega doses of vitamin and mineral supplements, which can be dangerous for both the pregnant woman and the fetus. Iron, zinc, selenium, and vitamins A, B6, C, and D can exert toxic effects when taken in large doses. Supplemental preformed vitamin A is especially important to keep under control because higher levels are linked to teratogenic birth defects, mainly during the first trimester. Many health professionals believe a pregnant woman should take nutrient supplements only when there is evidence that her usual diet is likely to limit maternal or fetal growth and development. A multivitamin and mineral supplement is recommended for women who have a history of frequent dieting, or teenagers or vegans, have a low income, are underweight, smoke or abuse alcohol or illegal drugs, or carrying multiple fetuses, and/or are eating a diet restricted in variety. Supplements of specific nutrients may be recommended in circumstances where these nutrients are inadequate. For example, vegans may need a vitamin B12 supplement. A low or moderate intensity exercise program can offer physical and psychological benefits to a woman experiencing a normal, healthy pregnancy. Benefits include improved cardiovascular function, an easier and less complicated labor, and an improved attitude and mental state. Exercise also can help prevent or treat gestational diabetes. Infants born to women who exercise tend to be leaner and more neurologically mature than babies born to non-exercisers. Women with high-risk pregnancies, such as those experiencing premature labor contractions, may need to restrict their physical activity. Recommendations for physical activity include moderate intensity for 30 minutes a day, drinking plenty of liquids, keeping the heart rate below 140 beats per minute, including a cool-down period. Pregnant women should avoid exercising while lying down after the 4th month, deep flexing, joint extensions, and jarring movements, increases in body temperature, discomfort, strenuous or endurance activities, and activities that could cause abdominal trauma. An infant's birth weight is closely related not only to the length of gestation, but also to the woman's pre-pregnancy weight and the amount of weight she gains during pregnancy. Starting pregnancy at a healthy weight and following weight gain recommendations increase the likelihood of a successful pregnancy outcome. Babies born to obese women have an increased risk of birth defects, including neural tube defects or oral clefts, being stillborn or dying in the first few weeks after birth, having high birth weights, being obese in childhood, and obese pregnant women may experience high blood pressure, gestational diabetes, and cesarean delivery. Babies born to underweight women have an increased risk of being low birth weight, being born premature, and lower nutrient stores. Many underweight and obese women experience difficulty becoming pregnant. Healthy weight gain during pregnancy promotes optimal fetal growth while minimizing risk of complications, postpartum maternal weight retention, and infants' chances of developing chronic diseases. Recommendations are based on pre-pregnancy BMI. Women of normal pre-pregnancy BMI should gain between 25 to 35 pounds. Women with a low BMI should gain 28 to 40 pounds. Women with a BMI of 25 to 29.9, which is overweight, should gain 15 to 25 pounds. And women with a BMI over 30, which would be in an obese category, should gain 11 to 20 pounds. The pattern the woman's weight gain follows is as important as the amount she gains. During the first trimester, most women should gain about 1.1 to 4.4 pounds, most of which is accounted for by the enlarging breast and uterus. After that, a woman who starts a normal weight gain should be about 0.8 to 1 pounds a week at a slow, steady rate. Underweight women should gain 1 to 1.3 pounds per week. Overweight women should gain 0.5 to 0.7 pounds, and obese women should gain 0.4 to 0.6 pounds each week. In the second trimester, weight gain is divided between the mother and the fetus. In the third trimester, weight gain is almost all fetal tissue. Low weight gain in either of the last two trimesters increases the chances of prenatal growth retardation. Low weight gain in the last trimester raises the risk of premature birth. Teenage pregnancy poses special nutrition and health challenges for both the mother and the developing offspring. Young women continue maturing physically for about 5 years after the onset of menstruation. Because the average age for menorrhagy is 13 years in the U.S., most women younger than 18 years old are not physically ready to be pregnant, as they will later. In addition to this, the teen years are a period of high nutrient needs, and teens' nutrient intakes frequently are below recommended amounts. It is difficult for a pregnant adolescent to consume adequate amounts of nutrients to support her own growth. It is even more difficult to meet the additional needs to support fetal growth. Many teens enter pregnancy underweight and gain too little weight during pregnancy. They also do not receive adequate prenatal care, and for all of these reasons, babies born to teens are at a greater risk of premature birth, prenatal growth retardation, and death soon after birth. Teens also have more stillbirths and spontaneous abortions than older women. Pregnant women with diets that deviate greatly from the recommended diet by either restricting dietary intake or eating excessive quantities of a limited number of foods risk getting too few nutrients and a poor pregnancy outcome. Ketosis can result from restricting carbohydrate intake or fasting and is not desirable for the growing fetus. Ketone bodies are thought to be poorly used by the fetal brain and may slow its development. Pregnant women can develop significant amounts of ketones after only 20 hours of fasting, so eating regular meals and avoiding fasting for more than 12 hours is important. Weight loss diets should never be attempted during pregnancy, regardless of pre-pregnancy weight or weight gain during pregnancy, because of the rise in ketones that can occur. Vegans need to consider sufficient intakes of protein, vitamin D, vitamin B6, iron, calcium, zinc, and vitamin B12. Numerous previous pregnancies and/or closely spaced pregnancies, less than 1 year apart, may deplete a woman's nutrient stores, which increases the risk that a subsequent pregnancy will result in a preterm birth, low birth weight infant, or small for gestational age infant. Carrying more than one fetus also increases nutrient needs and makes it difficult to consume sufficient calories and nutrients to support optimal growth of the fetuses. If prenatal care is inadequate, delayed, or absent, untreated maternal nutritional deficiencies can deprive a developing fetus of needed nutrients. Untreated chronic diseases, such as hypertension or diabetes, increase the risk of fetal damage. Without prenatal care, a woman is 3 times more likely to deliver a low birth weight baby. Individuals infected with HIV or AIDS have increased needs for energy and some vitamins and minerals. Supplements of some nutrients such as vitamin A, zinc, and iron may adversely affect those who are HIV positive. Pregnancy-induced hypertension impairs the delivery of oxygen and nutrients to the developing fetus. This can retard the growth and cause premature birth, and can escalate into preeclampsia and eclampsia. Preeclampsia is high blood pressure accompanied by protein in the urine, headaches, blurred vision, changes in blood clotting, nervous system disorders, and edema throughout the body. It can progress to eclampsia, which causes maternal convulsions and coma. Blood pressure may climb so high that the kidneys and liver are damaged, and both the mother and her fetus may die. Eclampsia is the leading cause of maternal and newborn death in the United States. Women with poorly controlled type 1 or type 2 diabetes are at a great risk of a poor pregnancy outcome. If blood glucose levels are elevated, the embryo or fetus is likely to have major birth defects that lead to spontaneous abortion, infant death, or serious infant illness. To prevent these consequences, women with diabetes need to work closely with their healthcare providers to bring their diabetes under control before pregnancy and keep their blood glucose at normal levels throughout pregnancy. During pregnancy, another type of diabetes, called gestational diabetes, develops in approximately 9% of women. Hormones synthesized by the placenta decrease the efficiency of insulin and lead to a mild increase in blood glucose. An excessive rise in blood glucose can lead to gestational diabetes, often beginning in the weeks 20 to 28. Some concerns with gestational diabetes are depleted fetal iron stores, having a large for gestational age infant, low infant blood glucose levels at birth, preterm delivery, an increased risk of birth trauma and malformations. There's a higher risk of the mother developing type 2 diabetes later on in life, and a higher risk of the infant developing type 2 diabetes and obesity later in life. Women with limited income or educational achievement and those who lack social support networks tend to have inadequate diets. To help women of low socioeconomic status get the foods and nutrient education they need, the U.S. Department of Agriculture funds the Expanded Food and Nutrition Education Program, which is EFNEP, the Supplemental Nutrition Assistance Program, which is SNAP, also used to be called food stamps, and the Women's, Infants, and Children Program, which is known as WIC. Some compounds in some foods should be limited during pregnancy. So environmental contaminants, and these are from the environment, which can enter food through containers, polluted waters, and farming and food preparation practices. Common food contaminants that are dangerous to pregnant women and the fetus are lead, mercury, PCBs, and pesticides. Lead can leach into food from lead crystal glasses, some dishes, and the solder used to seal copper water pipes. Fish are the food source most likely to be contaminated with mercury, PCBs, and other pollutants that were dumped into waterways. To minimize pregnant women's exposure to mercury, the FDA and the EPA advise pregnant women to avoid swordfish, shark, king mackerel, and tilefish, and keep their intake of other fish and shellfish to 12 ounces per week. Foodborne pathogens increase the risk of foodborne illness during pregnancy. Pregnant women should avoid foods frequently found to be contaminated with pathogens, such as raw sprouts, unpasteurized milk and juices, raw or undercooked meat, fish, shellfish, and eggs. Exposure to the bacterium that causes the foodborne illness, listeriosis, which comes from listeria, is especially dangerous during pregnancy. It can cause spontaneous abortion, premature delivery, stillbirth, and infections in the newborn. You can catch listeria from contaminated soft cheeses, such as Feta, Brie, and blue vein cheeses. Pregnant women are advised to avoid these cheeses for this reason, and they are also advised to cook leftovers and processed meats, such as hot dogs and deli meats, until steaming hot. Maternal exposure to the parasite that causes toxoplasmosis can lead to infant death or brain damage. This is found in cat feces, bird feces, and in the soil. Raw meat can also be contaminated with this parasite. To avoid toxoplasmosis, pregnant women should avoid litter boxes, kittens, and birds. You should also carefully wash all produce to remove any soil and cook all meat. Caffeine is a stimulant and diuretic which is found in coffee, tea, some soft drinks and energy drinks, and chocolate products. It is a common additive in many medications, and a high caffeine intake, such as more than 500 milligrams a day, can hinder a woman's ability to become pregnant and increase the risk of having a spontaneous abortion, a low birth weight infant. During pregnancy, caffeine can affect fetal heart rate and breathing and decrease blood flow through the placenta. Caffeine also may decrease the absorption of certain nutrients, such as calcium, iron, and zinc. Heavy caffeine use during pregnancy may lead to caffeine withdrawal symptoms in the newborn. There is evidence that caffeine consumption during pregnancy exerts a lasting adverse effect on the fetus, is limited, and very unclear. Many experts agree that it is sensible to limit caffeine intake during pregnancy to around 200 milligrams a day, which is about 2 cups of coffee or 3 cups of caffeinated soft drinks. Food additives, such as phenylalanine, which is found in equal, may be a cause for concern for some pregnant women. High amounts of phenylalanine in maternal blood disrupt the fetal brain development in the mother and can have genetic disease, phenylketonuria. If the mother does not have this condition, it is unlikely that the baby will be affected by moderate aspartame use. Some lifestyle choices can have important impacts on pregnancy outcome. Alcohol, drugs, herbal and botanical products, and smoking are lifestyle choices that increase the risk of poor pregnancy outcome. A woman should avoid substances that can harm the developing offspring, especially during the first trimester. More than half of all women in the U.S. of childbearing age consume alcohol. During pregnancy, alcohol may displace nutrient-dense foods in the mother's diet, and it also slows nutrient and oxygen delivery to the embryo fetus, retarding growth and development. Although the most severe damage occurs during the embryo stage, a time with many critical periods, consuming alcohol at any time during pregnancy can cause damage to the embryo or fetus that lasts a lifetime. Of every 1,000 babies born in the United States every year, as many as 5 have fetal alcohol spectrum disorders. These children are among the smallest in height, weight, and head circumferences for their age. Prenatal exposure to alcohol also may cause somewhat lesser effects, such as lifelong learning difficulties, short attention spans, poor coordination, and hyperactivity. No one is sure how much alcohol it takes to cause developmental problems. However, consuming as little as 1 ounce per day has resulted in mental and physical defects. Over-the-counter, prescription, and illegal drugs all have the potential to cause detrimental effects on a pregnant woman's nutrition status and pregnancy outcome. Common drugs that can cause problems during pregnancy include aspirin, hormone ointments, nose drops, cold medications, rectal suppositories, weight control pills, medications prescribed for previous illnesses, marijuana, and cocaine. Herbal and botanical products can exert potent drug-like effects on both the mother and the fetus. Until the safety of these products can be verified, experts recommend that pregnant women use all herbal and botanical products, including herbal tea, with caution and under the guidance of a healthcare professional. Nicotine and carbon monoxide affect the fetus when the pregnant woman smokes or is exposed to secondhand cigarette or cigar smoke. Smoking restricts blood flow, reducing the amount of oxygen and nutrients, especially zinc, that reaches the fetus, which in turn impairs growth. Smokers have an increased risk of spontaneous abortion and placenta problems. Lactation, also known as breastfeeding, is a natural physiological process of female mammals that occurs in the postpartum period when the mother's breast secretes milk and suckles the offspring. Preparation for lactation begins when a young girl enters puberty. Hormones, particularly estrogen, secreted during puberty, stimulate the growth and development of the mammary glands. The most obvious change in the breasts is their size, which is due to the deposition of fat. Mammary glands that develop in adolescence are inactive until pregnancy. At this time, hormones secreted by the placenta cause milk-producing glands to mature and ducts to branch. The manufacture and secretion of prolactin, which is the principal hormone that promotes milk production, are stimulated by the birth of the baby and by suckling. When the baby suckles at the breast, nerve signals stimulate the pituitary gland in the brain, causing it to release prolactin. The prolactin travels in the blood to the milk-producing glands in the breast and stimulates them to synthesize milk. If suckling stops or never occurred after delivery, prolactin is not released and milk secretion usually stops in a few days. The breasts gradually return to their pre-pregnancy state. During the earliest days of life, suckling is strongest in the first hour or so after birth, which makes this the best time to begin breastfeeding. In the days right after delivery, the baby should suckle often, at least every 2 or 3 hours for 15 to 20 minutes on each breast, to promote the establishment of lactation. After a few weeks, nursing sessions can become less frequent. As long as the mother breastfeeds her baby regularly, milk production will continue and can theoretically go on for years. Throughout lactation, the amount of milk produced closely parallels infant demand, which means that the more an infant suckles, the more milk that is produced. This is what makes it possible for a woman to adequately breastfeed even twins or triplets. To wean a child, it is best to gradually stop breastfeeding, usually by eliminating 1 daily feeding each week. Abruptly stopping causes the breast to become painfully engorged with milk for several days. An important brain-breast connection, commonly called the let-down reflex, is necessary for breastfeeding. The pituitary gland releases the hormone oxytocin, which causes the muscle-like cells in the breast tissues to contract and release, or let down, the milk from the lobules. The milk then travels through the ducts to the nipple area. During the first few weeks after delivery, this reflex must be triggered by the infant suckling the mother's breast. Once lactation is established, the let-down reflex becomes automatic. It can be triggered just by thinking about her infant or hearing a baby cry. It generally takes 2 to 3 weeks to fully establish a feeding routine in which both the infant and the mother feel comfortable. The milk supply meets infant demands, and the initial nipple soreness disappears. Establishing the breastfeeding routine requires patience, but the rewards are great. Colostrum, transitional milk, and mature milk are the successive types of milk produced while lactation is being established. Colostrum, which is the thin, yellowish, immature milk, may appear any time from late pregnancy to several days postpartum. This early milk is richer in protein, minerals, and vitamin A than later milk, but it has less carbohydrate and slightly few calories. It also contains antibodies and immune system cells, some of which pass unaltered through the infant's immature GI tract into the bloodstream and provide the infant with a defense against some diseases during the first few months of life when the immune system is very immature. The early first few months of life are the only time when we can readily absorb whole proteins across the GI tract. Colostrum contains a potent laxative, which helps the infant excrete the fecal matter that is collected in the intestinal tract during fetal life. The colostrum gradually changes in the early days after delivery to become transitional milk, which contains more fat, lactose, water-soluble vitamins, and calories than colostrum. Within a week or so, transitional milk is replaced by mature milk. Mature human milk is thin and almost watery in appearance, and often has a slightly bluish tinge. It provides about 20 calories per ounce, and, with the possible exceptions of vitamin D and iron, supplies all the nutrients the growing baby needs. The ingredients for breast milk come from the mother's diet and maternal stores. Many women consume less calcium, magnesium, zinc, folate, and vitamin B6 than recommended, and special considerations are water and calories. Water is the main component of human milk, like other milk. Inadequate water intake can alter milk composition, decrease the amount of milk produced, and lead to maternal dehydration. A breastfeeding woman should drink to satisfy her thirst. Most need an extra 32 ounces of fluid daily, in addition to the 72 ounces recommended for non-pregnant women. Calorie needs can be met by eating the same number of servings from each food group as recommended for pregnant women in the last 2 trimesters. The average breastfeeding woman uses about 800 calories per day during the first 6 months of lactation to produce 750 milliliters, or 3 cups of milk daily. Approximately 400 to 500 calories should come from her diet, with the remainder supplied by the fat stored during pregnancy. Lactating women can enjoy all foods in moderation. A serving of a fortified ready-to-eat breakfast cereal or a multivitamin and mineral supplement can help meet extra nutrient needs. They should consume adequate amounts of omega-3 fatty acids from fish or supplements, and they may want to avoid peanuts and peanut butter because it may result in an infant developing a peanut allergy. There are many advantages of breastfeeding for mothers, such as earlier recovery from pregnancy due to the action of hormones that promote a quicker return of the uterus to its pre-pregnancy state. There is a decreased risk of ovarian and premenopausal breast cancer, potential for quicker return to pre-pregnancy weight, potential for delayed ovulation and therefore reduced chances of pregnancy, potential bone remineralization to levels exceeding those before lactation, less postpartum bleeding, reduced risk of type 2 diabetes among women with no history of gestational diabetes, reduced risk of metabolic syndrome later in life, reduced risk of rheumatoid arthritis if the mother breastfeeds for more than 12 months during her lifetime, decreased feelings of depression in postpartum period after childbirth, lower household food costs. Some factors affecting lactation is maternal weight. Obese women have greater difficulty initiating and continuing breastfeeding. Maternal age, breastfed babies of adolescent mothers may grow more slowly. And maternal eating patterns. If the mother's diet is poor for several weeks or months, maternal nutrient stores may be depleted and the milk supply negatively affected. Breastfeeding may be ruled out by certain medical conditions in either the infant or the mother. Breastfeeding may be detrimental to infants with the inborn error of metabolism, fetal ketonuria, or galactosemia. The high concentration of phenylalanine and galactose in human milk may overwhelm the impaired ability of these infants to metabolize these nutrients, leading to serious illness and even death. If the mother has infectious or chronic diseases, or if the mother has breast surgery, which may affect a woman's ability to produce milk and/or secrete it. Some sociocultural factors that can affect breastfeeding is a lack of information, low self-confidence, lack of role models, and/or inadequate support. In almost every community, there's a group called La Leche League, which offers classes in breastfeeding and advises women who have difficulties with it. Compounds in the food the mother eats can be secreted into her milk. Environmental contaminants, such as pollutants and pesticides, can appear in human milk. The benefits of human milk are well established, and the effects of environmental contaminants on the breastfed infant have been seen mostly when the mother herself was suffering from the effects of the contaminants. To counteract some contaminants, avoid freshwater fish from polluted waters, carefully wash and peel fruits and vegetables, and remove fatty parts of meat. Do not try to lose weight too fast while nursing, and caffeine may make infants fussy. Certain foods and their compounds may cause infants to become upset or not want to eat, such as garlic, alcohol, cabbage, or broccoli. Substances related to lifestyle choices, such as alcohol, drugs, herbal and botanical products, and nicotine, are also secreted into breast milk. Alcohol, especially beer or wine, was recommended for centuries as a way for new mothers to relax and allow babies to nurse longer. But current research shows that consuming alcohol actually reduces milk output and causes baby to drink less and have disrupted sleep patterns. The safest route for mothers and babies is to avoid alcohol altogether. However, lactating women who want to drink alcohol are advised to limit their intake and wait 3 to 4 hours before nursing again. The amount of alcohol in breast milk peaks about 30 to 60 minutes after the mother ingests it, then declines. Many herbal and botanical products contain drug-like compounds, which may appear in milk. All herbal and botanical products should be used cautiously during lactation. Smoking also affects breastfeeding success and safety. In comparison with non-smokers, women who smoke or breathe secondhand smoke produce less milk, and their babies gain less weight.